Hi, everyone, and welcome to the Department of Medicine's Grand Rounds. My name is Dr. Nicole Parellada, and I'm one of the chief medical residents. Today, I will be introducing both of our presenters. First up, we have Dr. Pedro Cox. He currently serves as the medical director of the Structural Heart Valve Program here at the University of Miami. Originally hailing from Puerto Rico, his academic journey began with a Bachelor of Arts from the University of Michigan, followed by a Master's of Public Health and Health Policy and Management from the George Washington University School of Public Health. He earned his medical doctorate degree from the UCC School of Medicine and completed internal medicine residency at an MAH, Harvard Medical School Associated Hospital. He completed cardiology fellowship at the University of Puerto Rico School of Medicine, interventional cardiology fellowship at the University of Florida College of Medicine, and an advanced interventional cardiology and structural heart valve intervention fellowship at Ochsner Medical Center in New Orleans, Louisiana. A pioneer in developing heart valve programs across the U.S., Dr. Cox previously held the position of Associate Professor of Medicine at LSU and was the system-wide director of the Structural Heart Valve Program at LCMC, the largest hospital system in Metro New Orleans. He was instrumental in developing various cutting-edge programs, including transthoracic valve replacement program and the only accredited comprehensive adult congenital program in Louisiana, in collaboration with the Heart Center of the Children's Hospital of New Orleans. Beyond patient care, Dr. Cox is dedicated to enhancing the well-being of underrepresented communities. His efforts extend to health policy, where he has served as a health legislative aide in the U.S. House of Representatives and a consultant to the WHO and deputy advisor to the governor of Puerto Rico. He was notably the youngest member appointed to the Puerto Rico Health Insurance Administration Board, overseeing managed care organization and serving Medicaid recipients in Puerto Rico. He is actively involved in clinical research, contributing to numerous protocols and publishing extensively in peer-reviewed medical journals, such as Arteriosclerosis, the Journal of the American College of Cardiology, the JACC Cardiovascular Interventions, and the Journal of the American Heart Association. Dr. Cox, I extend a warm welcome to the Department of Medicine's Grand Rounds.
Nicholas, thank you for such kind of introduction. And thank you so much. Today, I have a short talk to give. I think I have 20 to 25 minutes, so I try to be brief. I'll be talking the subject of left atrial appendage occlusion, the current trends in use and outcomes. These are my disclosures, nothing related to this talk. As a matter of introduction and outline, we'll be talking about, an introduction. We'll talk about some randomized clinical trials. We talk about some issues regarding the devices approved. We talk about the overview of the procedure, a case, and then a summary of the conclusions. So as an introduction, 12 million patients with atrial fibrillation in the US by 2030. Atrial fibrillation increases the risk of stroke by fivefold. 25% of ischemic strokes are associated with atrial fibrillation, and direct oral anticoagulation remains as the main therapy for stroke prevention due to the lower risk of ICH in comparison to warfarin, and more than 250,000 patients have been treated with left atrial appendage closure worldwide. On the image on your left, on the right, you can see an ultrasound image showing the left atrial appendage. Inside the pouch, you can see a moving structure that's a clot. And the atrial fibrillation due to the inadequate contraction of the upper chambers of the heart, there is a less effective blood emptying, which can leads to blood stagnation, clot formation, and these clots can actually travel outside the chamber of the heart, causing a stroke or a thromboembolic event. And this is the issue with atrial fibrillation. The multi-society guidelines recommend oral anticoagulation in patients with non-valvular atrial fibrillation to prevent strokes. And they recommend us to use a score called the CHAD-VAS score to risk stratify these patients. And if their CHAD-VAS score is more than 2 in men or 3 in women, the recommendation is to start oral anticoagulation. However, striking the balance between stroke and bleeding can be difficult. It's like sometimes walking in a tightrope. These are elderly patients, in the most of them. And we need to, it's sometimes very difficult to strike the balance because patients with a high SHAT-BAS score can also have a high incidence or risk of bleeding. So we need definitely to tailor stroke and bleeding risk to the patient's treatment plan. Again, the adherence to oral anticoagulation is a challenge. About half of patients with atrial fibrillation are not treated with oral anticoagulation despite the risk of stroke. The use of oral anticoagulation in these patients peaks at a 50%. Of those taking oral anticoagulation, a significant number of patients will stop. 30% of patients taking the direct or novel anticoagulants may stop, and 50% of the patients taking coumarin discontinue the treatment in 2 years. In addition to adherence and tolerance issues, direct oral anticoagulants also carry a risk of significant bleeding complications. Clinical trials for direct oral anticoagulants show similar major bleeding rates to warfarin, and even higher discontinuation rates than in comparison to coumarin. So many patients are not great candidates for oral anticoagulation. Others are not candidates at all. And it's in this type of population that left atrial appendage occlusion has been studied and developed for the last, I would say, 20 years. And the rationale behind doing this is that we, by using a standard percutaneous technique, a wire, a dilator, we access the femoral vein. We cross the intra-atrial septum using a transeptal access system. We navigate ourselves into the left atrial appendage, and then we deploy and release a device inside that pouch, which will permanently seal the left atrial appendage and will be fully endothelialized in a couple of weeks. So this is a permanent implant through a minimally invasive technique that will prevent strokes in a lifetime in patients that are not candidates for oral anticoagulation. And again, the clinical timeline has not been short. This timeline started in 2002. 2 randomized trials, the PROTECT and the PREVAIL trial, followed by registries that gave the final approval by the FDA in 2015 as an alternative to oral anticoagulation in patients that were high risk, and then more registries. By then 2019, we see a new generation of the device. We see 2 companies with similar devices commercially available to us. And now we are in the 3rd generation of the Watchman device that has been recently approved in 2030. So, and we will talk a little more about the devices, the major trials, and the registries. The PROTECT atrial fibrillation trial was the first randomized trial who enrolled patients with high risk of stroke and bleeding during 2005 and 2008. And the primary efficacy endpoint was stroke, systemic embolization, or cardiovascular death. And the primary safety outcome was composite of major bleeding events and procedure-related complications. These patients were followed for 4 years. And on the left, you can see that the primary efficacy endpoint was not only non-inferior, but also superior in favor of the device arm. And the safety endpoint was similar between groups. When you look at the components of ischemic stroke, there was no difference between the device or warfarin group. However, in the long-term follow-up, there was a statistically significant difference in favor of the device arm in cardiovascular mortality and all-cause mortality risk reduction. So at the end of almost 4 years follow-up, the percutaneous left atrial appendage device was proved to be both non-inferior and superior to warfarin in preventing strokes, systemic embolism, and cardiovascular death. Also demonstrated superior results in reducing cardiovascular mortality and all-cause mortality. One important finding was that the incidence of pericardial effusion, which was about 4.8%. This led to the FDA mandate another trial before the final approval of the device in the United States. And that second randomized trial was the PREVAIL randomized trial that enrolled patients between 2010 and 2012. It was again a multi-center randomized controlled trial to assess the safety and efficacy of left atrial appendage closure in patients that are high risk for oral anticoagulation and a CHA2DS2-VASc score of more than 2. And again, the left atrial appendage occluder was non-inferior to warfarin for ischemic stroke prevention or embolization, and proved to have a procedural success and safety better than the PROTECT trial. Based on these two randomized trials, the FDA did approve this device and technology in 2015. And subsequently, 5-year outcomes of both the PROTECT and the PREVAIL trials have been analyzed on a patient-level meta-analysis, and they found that the device provides stroke prevention to a similar degree of oral anticoagulation with warfarin. Compared to warfarin, the device is associated with a reduction in hemorrhagic stroke, disabling and fatal strokes, major bleeding, all-cause mortality, and cardiovascular mortality. Very important outcomes from long-term follow-up trials. We also have trials coming from Europe comparing new oral anticoagulants to the device. This is the PRAC-17 trial. 402 atrial fibrillation patients randomized to direct oral anticoagulation. Remember, again, the PROTECT and the PREVAIL were on warfarin only. The primary endpoint of stroke, TIAs, systemic embolizations, cardiovascular death, bleeding, or complication. And it was found that the device was, again, non-inferior to direct oral anticoagulation in this population. And again, this is another meta-analysis of the three trials that I have just mentioned. No significant difference between the device and oral anticoagulation in all stroke and systemic embolism, major reduction in hemorrhagic stroke, and a significant reduction in cardiovascular and all-cause mortality, and a non-procedural major bleeding was also significantly decreased. So very good results with these trials. So when we talk about the registry, the CMS and Medicare mandates all hospitals in the US to be part of the NCDR registry. And this is data coming from the registries from 2016 to 2018. Around 40,000 patients, 500 hospitals, 1,300 implanted physicians. Again, a population that's older and higher bleeding risk and stroke risk than the patients that participated in the trial. And we can see that the safety is comparable to the pivotal trials. More importantly, we see that the incidence of pericardial effusion recurrent intervention is only 1.4% compared to 4.8% that we saw in the PROTECT trial, which was why the FDA mandated another trial. But with an increased experience, you can see that from an all-comers registry that the incidence of pericardial effusion has come down tremendously. When we go to the device success rate, again, patients close to 99% of patients are successfully implanted with a very low event rate of complications. So very, very safe device. So just to give an overview, these are 3 generations of, for example, of the Watchman appendage closure device. The main differences span from anchors, how do you recapture, how they can have less trauma to the cardiac tissue, better visibility, and most importantly, coating so that they're thromboresistant. The image on the far right is basically an image showing also how strong are these devices in terms of the fiber that they use. There has been also trials to show between devices, how these newer devices, how do they compare to the older devices? And we can see definitely an improvement with these technologies regarding incidence of leak, of pericardial effusion, thrombus, embolization, and pericardial effusion. The other device that's commercially approved in the US is the Amulet device. This is the Amulet IDE trial, which almost had 19,000 patients randomized to Amulet or to Watchman device. Again, high-risk patients were bleeding and stroke in patients with non-valvular atrial fibrillation, and the 3-year outcomes presented here show that the risk of systemic or cerebral embolism, bleeding, death, or device-related thrombo was no different between groups, between devices. And the image on your right is the Swiss Aperol trial, which is a trial from the Europe, comparing again both devices with some differences regarding outcomes, not major complications, but just some things that we will need to follow in regarding device leaks and effusion. So what about the guidelines say about the percutaneous approaches to occlude the left atrial appendage? The multi-society guidelines give a 2A recommendation to use the left atrial appendage occluder in patients that have long-term contraindication to oral anticoagulation. And then it gives a 2B recommendation for patients that may have a reasonable alternative to oral anticoagulation based on patient preference. Again, a 2B. It also gives us some examples and situations where oral anticoagulation can be contraindicated, especially in patients that have causes of bleeding that are not reversible. Definitely a major change in the current guidelines. And we expect that the next guidelines might change these recommendations to a more robust 1A recommendations, pending the clinical trials that are ongoing. A very interesting thing that also happened was the societies sent a memo to CMS so that CMS also recognizes 12 potential patient examples for rationales to seek an alternative for oral anticoagulation in these patients. And just to mention a few, patients with increased risk of bleeding that is not reflected by the Hasbled score, like for example, patients with thrombocytopenia, patients that have cancer, patients that have risk of tumor-associated bleeding, that I think we actually see a lot here. The need, patients that have the need for prolonged in dual antiplatelet therapy, patients with occupation related to high bleeding risk, patients with cognitive impairment, patients with high risk of falls, inability or difficulty on maintaining a therapeutic INR. These are only to mention a few. So after just changing gears, after we implant the device, there's 2 ways to post-implant drug regimen options. All these options are under the discretion of the operator and depending on the patient risk factors. At the beginning of the trials, we were discharging these patients on oral anticoagulation and aspirin for 45 days, then aspirin and Plavix for 6 months, and then aspirin as a destination therapy. Now we know that we can those patients can be actually go directly into aspirin and Plavix, and then after 6 months go to aspirin alone as a destination therapy. So what are the current issues with these devices? We mentioned in the previous slides a good success rate and improved in pericardial effusion requiring intervention. But 2 issues remain that we need to keep in mind. One is device-related thrombus. Sometimes we see this thrombus in the device when we do a follow-up TE and CT scan after 6 weeks of implantation. The incidence has been found to be around 2 to 4%, and there is a 2 to 4-fold increase in thromboembolism in patients with DTR. And there's some predictors that have been mentioned, and here's some data. Looking at the registry on patients with left atrial appendage occlusion who develop DTR on images. What we know is that 65% of patients that DTR or device-related thrombus were resolved with oral anticoagulation. However, 1/3 has persistent DTR and higher risk of strokes and thromboembolic events. So this is definitely an area of interest ongoing research that, however, low incidence, but very interesting findings that I think is going to give a lot of news and a lot to talk in the coming future. The other issue is peri-device leak after left atrial appendage occlusion. The initial randomized controlled trials define a significant leak of 5 millimeter as the cutoff at 6 weeks, identified by TE or CT scan in patients with less than 5 millimeters of leak. Oral anticoagulation was stopped. But we know now that that might not be so trivial, and we have seen studies that leaks of 3 to 5 millimeters might not be that benign, may be related to stroke. A different type of treatment has been described for these leaks, such as coils, maybe putting a second device, maybe, you know, doing better coaxiality during the implantation, using a larger device, better CT planning to do these cases. But definitely, again, a very interesting area that we will be seeing in the future, and we'll see more devices to make better or maybe to significantly reduce the incidence of peri-device leak. To go back to what is this appendage and to what is it that we're looking into as cardiologists, this is a TEE image of the heart, and we're looking at the left atrial appendage. We know that we have an anatomic orifice. We know that we have an echocardiographic orifice, and we have the body of the appendage, and this is the neck of the appendage. And we have devices that will, in some sort of another, close either one or the body or the neck or both. The commercial devices that we do have available right now, the Watchman and the Amulet, the Watchman will close the body of the device, and the Amulet will be closing the neck and the body of the device because of the mechanism of how they were developed. In regards to the procedure overview, this is a pretty straightforward procedure in the realm of interventional cardiology. It's fluoro guided. It's we have to use imaging, a transesophageal echo. Patients, for the most part, are under general anesthesia. We at least need 4 orthogonal views to look at the largest diameter of that appendage so that we can choose the size of device that we're going to be using. We need to be very precise, again, in the transeptal puncture, because we need to navigate from the right side of the heart to the left side of the heart, and then putting a device in the left atrial appendage. We have to be, again, also very careful in the way we navigate into the left atrial appendage, because this is a very thin structure in the left atrial, in the left atrium, that can easily perforate if we are not careful. And then after when we place the device, we definitely need to meet certain criteria to release the device. We need to know that the position is right. We need to know that the anchor and the fixation is engaged. We need to see that the size is the correct one. And we want to make sure that everything is sealed so that we don't have any of that peri-device leaks that I mentioned earlier, okay? At the end, you know, this is just a slide showing how many of these devices are undergoing development as we speak, with improved sealing of the device, reduce the incidence of thrombus in the device or leaks in the device. And this is a very, very exciting and evolving field. A couple of these devices were mentioned and we were showed in the Miami Valves recently this year. The laminar device, for example, had a lot to say to the audience. Definitely a lot happening on this area. So going back to the selection of cases, I just want to show one case of a case scenario. You know, this we can say so many things, but this is a 75-year-old comes to your office to establish ongoing care, and he has atrial fibrillation for the past 5 years. He's in well-controlled medications. However, he likes to ski. He loves the outdoors. He really don't want to take oral anticoagulation. And there is definitely a couple of options that we can have. After this lecture, I hope that you will, I guess you will say percutaneous approach, but there's other ways to deal with it. What we do know is that what not to do. Right? I think the recommendation definitely would be to continue some sort of prevention stroke strategy. I mentioned here the epicardial occlusion because it's not a percutaneous occlusion, but yes, there is surgical ways of closing the appendage, definitely more invasive than the percutaneous ones. But definitely this conversation should be had with patients, I think, and the more we involve the people that do them and get a better perspective, I think the better we can choose the patients and educate the community and give the options that they so much want, regardless of what the option is, right? In the end of the day, we
2 minutes,
think,
Dr. Cox, 2 minutes.
yes, in the end of the day, I think we should recognize what patients are we referring today for Watchman. I hope that at some point we'll go from only not referring the secondary prevention patients, the patients that already had major bleedings or major issues with oral anticoagulation, but rather the patients that had primary, that we need to have primary prevention, patients with risk of fall, person with another medication that increases the risk of bleeding, and patients that have major side effects caused by blood thinners. So in summary, there has been an increased adoption of these procedures to prove safety and efficacy in stroke prevention for AFib. There's key concerns, peri-device leak and device-related thrombus. There's ongoing trials. We continue to do research and development of these technologies to promise enhanced safety and efficacy. And clinical trials will inform the future guidelines and best practices for stroke prevention going forward. Thank you so much. And with that, thank you for the invitation.
Thank you, Dr. Cox. We have time for 2 minutes worth of questions. Maybe I can begin. These Watchmen have been around for a while now. Other than the immediate problems associated with device implantation and even perhaps longer term and thrombus formation on the device or leakage and so forth, what's the longest that people can really benefit from this? Is this for a lifetime that they're protected, or do these devices need to be changed at some point?
That's a great question. These devices will stay there permanently and seal off the left atrial appendage forever. So it's a lifelong protection for stroke prevention. So yes, you don't have to do anything else. If you have a perfect implantation with zero leak, no issues with thrombus, again, it's less than 4%. Those devices will stay there permanently and will fix your issue for the rest of your life.
So Dr. Lakakis has a question in the chat and wants to know, why even consider DOACs? Why not just use the left atrial appendage insertion?
That's a great question. I think going forward, that's a question that's still on trials. I think that the technology was approved for secondary prevention. Obviously, the people that were extremely high risk for bleeding. I think that going forward, there is some trials going on right now to answer that question. Until the trials and the results come, I think, it's something that we talk about, but I would not be giving a complete recommendation. I think that in the future, yes, we might see an instance of this becoming maybe the main therapy for a protection of stroke in these patients. Having said that, for example, there has been a trial from the surgical world where people with atrial fibrillation undergoing open heart surgery, there's a clear benefit to close the left atrial appendage the same time they go through an open heart procedure. I think that, and they're doing that, it's kind of like a standard of care nowadays. So there's something that I think at the long term, it's going to happen. Maybe also with the Watchman devices. Again, I have to be very precise, because we need to understand that if you have a perfect implantation with no complication, I think, yes, this will be the way to go.
Thank you, Dr. Cox. We'll have to move on to our next speaker. Thank you very much for this excellent presentation. Nicole, I'm going to introduce our next speaker. Sorry, Dr. Chatzitsas.
Okay. Thank you, Dr. Cox, for that great lecture on left atrial appendage occlusion. I'm sure it's something I will be seeing a great deal of in the future. Now we have our second presenter, Dr. Watson. Dr. Dionysios Watson is a physician scientist dedicated to elucidating and therapeutically targeting tumor microenvironment interactions in solid tumor malignancies. He is currently assistant professor in the medical oncology division, leading an NIH-funded independent research laboratory as part of the Sylvester Comprehensive Cancer Center. His clinical practice focuses on lung and head and neck cancers. He is currently assistant professor in the medical oncology division. As I said, after completing medical school in Greece, he went on to complete his PhD training in immunotherapy development at the National Cancer Institute. While there, he led translational and clinical efforts for development of heterodimeric interleukin-15 for cancer immunotherapy. He completed internal medicine residency and medical oncology fellowship at Case Western Reserve University and conducted his postdoctoral research training at the Cleveland Clinic, where he discovered intercellular mitochondrial exchange in the brain as a driver of glioblastoma, the most commonly primary malignant brain tumor. He is passionate about increasing accessibility of cancer therapy, both in the US and internationally. Please join me in welcoming Dr. Watson to the second part of the Department of Medicine's Grand Rounds.
Thank you so much, Nicole, for your introduction. And of course, thank you to Dr. Weiss for his kind invitation. Today, I'm just going to do like a lightning rounds, updates in oncology, focusing on solid tumors. So I have no disclosures, and if I talk about anything off-label, I will make sure to tell you it's off-label. Objectives for today. So one, obviously, we're going to be talking about updated treatment guidelines for a variety of solid tumors. And there are really a lot of interesting and exciting developments with new therapeutic classes. So I'd like us to become familiar with some mechanisms of action of two of those, at least: antibody drug conjugates and tumor infiltrating lymphocyte therapy. So outline, again, this is going to be like lightning round. So I just organized this anatomically. And if we run out of time, we can stop at any point, and we will not have ruined the flow of the presentation at all. Okay, so let's start at the top. Let's start at the brain. So glioblastoma, the most common malignant brain tumor, treatments are very, very limited, and several groups are trying to develop CAR T cells targeting various tumor antigens expressed in these tumor types. So two recent clinical trials have come out. One of them developed IL-13 receptor alpha-2 targeting CAR T cells. Another one targeting EGFR variant 3, which is often a mutated variant in GBM. And both of these were phase 1, essentially assessing safety, and they showed transient and manageable toxicity, which is quite important when you're trying to activate immunity in the brain and delivering immune active cells to brain tumors. When we look on the flip side at the efficacy, the trials both showed some promising results with early transient responses. In the second trial here with the EGFR CARs, there were regressions reported even after 1 day of infusion. However, the response rates tended to be low and not usually prolonged. So CAR T cells for GBM, promising, yes, but not yet ready for prime time, unfortunately. On the flip side, we can look at melanoma. So looking at cutaneous oncology, melanoma is really one of the poster childs of immune therapy. And we had recently the first approval of a tumor infiltrating lymphocyte therapy for a solid tumor. The drug is called lifileucel, and this is for patients with metastatic disease that has progressed on the currently FDA-approved treatments. The difference between this and CAR T cells, so here, essentially, we resect tumors and then expand the T cells that are in the tumor, take those cells with really not much modification and reinfuse them to the patient. So now essentially the cells that have anti-tumor specificities that develop in the patient go back and are able to attack the tumor. And this is different from CAR T cells, where we actually modify the T cells to express an antibody recognizing cancer. And this study showed excellent response rates of about 30% in the phase 2 trial I'm showing here, with overall survival in this refractory group of over 50% at 1 year, 22% at 4 years, with really manageable toxicities associated primarily with some of the chemotherapy that needs to be given. So excellent results and obviously practice changing for metastatic melanoma. So moving on now to thoracic oncology, which is my area of interest. There's been a lot of interest in developing targeted chemotherapies. So instead of just delivering chemotherapy to the whole body and having a lot of toxicity, we're now able to develop these antibody drug conjugates for particular tumor antigens. And to give you an idea of how these work, you start with a tumor antigen. In the case that I'm of this study, it's talking about HER2, and you develop an antibody that targets this antigen. And in this case, we're able to conjugate highly potent chemotherapies to the antibody. And these are chemotherapies that are too toxic to be given systemically, without any targeting. So now we have an antibody drug conjugate that can bring the chemotherapy specifically to the tumor cells expressing a particular antigen. And then this drug is internalized typically where the drug is released. And we have really 3 mechanisms of action that have been proposed for these drugs. So number 1, there's direct cell killing. Obviously, if you internalize the drug, as a tumor cell, you can get killed. Even if there are tumor cells that are adjacent that don't express the antigen, there is bystander killing just by virtue of releasing locally this potent chemotherapy. And then finally, number 3 here, because there's widespread release of tumor antigens and damage signals from the dying cancer cells, there's also thought to be a triggering of anti-tumor immunity locally at the site of the tumor. So the study that I'm summarizing here involved, again, an ADC targeting HER2. The ADC is called trastuzumab deruxtecan. It's been used for several years now in breast cancer. But as a result of this trial, we now have it approved for HER2 overexpressing lung cancer as well in the metastatic setting. The main toxicity of a lot of these ADCs that is concerning is actually interstitial lung disease. It's something you don't typically see with just the chemotherapy. And we're not exactly sure why this happens, but part of it likely has to do with trapping of antibody in the actual lungs and causing toxicity. Perfect. Now, another type of cancer in the lung that many of you are aware of is small cell lung cancer. And this is very different from the majority of lung cancers that we treat with. It does not respond to most of the approved therapies. And in fact, once patients progress on first line, there really are not great options. There are things approved, but they don't tend to work very well once you progress on first line treatment. So really after many years of not having great approvals, there is a completely new drug that has been approved for metastatic small cell lung cancer. And this is a bispecific antibody, so a bispecific T-cell engager for an antigen called DLL3. DLL3 is expressed on the tumor cell, so on the small cell cancer cell here in red. The antibody binds to this tumor antigen, and then the other end actually binds to CD3 on T cells, and forming a bridge between the 2 cells. So essentially, you're recruiting T cells to the surface of the small cell cancer cell and also activating the T cell, allowing it to kill the cancer in an immune dependent manner. These have been used in lymphomas, different versions, obviously targeting different antigens have been used in lymphoma, but now we also have an approval in small cell lung cancer. The indication right now is for extensive stage, so that's typically either locally or distant metastatic spread of the disease. We don't need to test for DLL3 because actually more than 90% of these cancers express the target. So as of today, we don't need to test before treating. And patients do need to have progressed on first-line chemotherapy with platinum like cisplatin or carboplatin. Overall survival at 9 months was more than 65%, which again is quite promising compared to other second-line treatments. And toxicity is similar to what we see with CAR T cells and other bispecific T cell engagers, and involves a cytokine release syndrome. The last thing I'll talk about for the thoracic cancers is using a targeted agent that we've had for years, using it in earlier stage disease. So alectinib, this is a small molecule drug that specifically targets ALK mutations and fusions, so alterations in non-small cell lung cancer. And up until now, we've used it only in metastatic disease with really excellent efficacy. And finally, after a large study where it's been approved also for surgically resected disease in the adjuvant setting. And you can see here, compared to chemotherapy as adjuvant, which is the standard, there's a huge difference in the disease-free percent of patients at 2 years. So 94% of patients are disease-free 2 years after resection, as compared to 64% in the standard chemotherapy adjuvant group. Okay, so head and neck cancers. So here, head and neck cancers, in early stages, we do quite well with treating them. As they get advanced, things become more challenging, and there haven't been a lot of new developments that are approved in this space just yet. In nasopharyngeal carcinoma, which also can affect younger people, we have now addition of immune therapy to a chemotherapy backbone. So toripalimab is an anti-PD-1 inhibitor, so a checkpoint inhibitor, and added to chemotherapy to what is now a standard chemotherapy regimen, you can see that progression-free survival in metastatic disease nearly triples, and OS hasn't been reached yet, as opposed to almost 3 years in the standard chemo alone arm. So as Nicole mentioned, I'm a big fan of immune therapy. I studied in the lab, and so I was glad to see that immune therapy wins again. Okay, moving on now to breast oncology. So we'll talk about something that's not approved yet, but maybe soon. So this is talking about ribociclib. So this is a CDK4/6 inhibitor that has been used for several years now in metastatic disease. But people are trying to see, as with most agents that are approved in advanced disease, they're trying to see, can we start treating patients earlier on? And the two studies I'm highlighting here from last year are looking at either adjuvant use of ribociclib, so after surgery, or in the neoadjuvant setting before surgery. And the thought of a lot of these is A, can we improve the cure rates for earlier stage disease? And B, in cases where maybe the outcomes are already good, can we omit chemotherapy to help with the tolerability of adjuvant or neoadjuvant treatment? And both of these studies had quite favorable results. The patient populations were a little bit different. In the adjuvant setting, they were looking at HER2-negative disease that was hormone receptor positive, and in the neoadjuvant, this was HER2 positive. But really, for unless you're treating breast cancer, the key takeaway message here, and the reason I pooled these together, is that giving ribociclib, so giving CDK4/6 inhibitor early on, is efficacious. And you can see here disease-free in the one study, 90%, versus 87% without without the CDK4/6 inhibitor in the neoadjuvant setting. Comparable disease-free rates, whether you have chemo or not. So bottom line, I think there is promise to adding a CDK4/6 inhibitor earlier on in treatment, but really we need to wait a few years for the data to mature and perhaps have some FDA approvals. We'll do one on sarcoma now. So sarcomas are not your most common cancers. They're cancers of muscles, bones, connective tissue. They're very, very diverse. And so there's a lot of science trying to understand how they're different and how we can target each one more specifically than we do today, which today is really just chemotherapy, more or less the same for most of the sarcomas. So anyway, in these particular types of sarcomas, so we're looking at a synovial sarcoma and myxoid round cell sarcomas. There's ongoing development of a T cell receptor engineered product. So specifically, this involves taking T cells from patients, so apheresing from the blood the T cells, and then engineering them to express T cell receptors that specifically recognize the MAGE-A4 tumor antigen on the tumor cell. And now you have T cells that can go find these specific tumor cells, recognize them, and kill them. TCR, so T cell receptor products, have some benefits over CAR-Ts. They also have some limitations. So, taking you back to your immunology lessons in medical school, if you're not actively working on it. So TCRs specifically need to bind to an MHC complex of a particular allele and match in order to be able to bind and recognize a peptide antigen. So as you can see in this study, it was limited to patients that express HLA-A02, that specific allele of HLA. And in those patients, response rates in this early phase trial were quite good. This was metastatic disease that's previously treated, tends to be very resistant to chemotherapy. And when it came to response to this product, so to this TCR engineered T cell, response rates were almost 40%. And again, this is quite promising for this highly resistant disease, patient cohort. Perfect. We'll move on to something a little more common now. So colon cancer, of course, more common than sarcoma, but a specific subset of colon cancer that is deficient for mismatch repair. So MMR deficient for short. These are colon cancers that have certain mutations typically that do not allow them to repair their DNA. And so they have a lot of mutations that the immune system can recognize. And we've had for years now approved PD-1 inhibitors as monotherapy for these types of colon cancers. They tend to do very well. And a study looked at combining now two different checkpoint inhibitors in a combination that's widely used in melanoma as well as other types of cancers. So ipilimumab plus nivolumab. And they compared this to chemotherapy in this patient cohort. And of course, the results, nobody can be really surprised with them. The results were very good. 2-year PFS was 72% in the immunotherapy arm, as opposed to 14% on the chemotherapy arm. I've noted below, we don't really know in this particular setting, at least not with this data and not with big studies, whether the combination is better than the already approved monotherapy with a single checkpoint inhibitor. We do assume that it potentially is more effective because of data in melanoma and other tumor types, but we don't know, and the study hasn't been done yet. Dual therapy does have more side effects. So this is FDA approved. The combination is approved now, and you could consider it for patients that may tolerate the combination as opposed to monotherapy. And now to a question, age-old question in oncology, and in almost every tumor type, you will find a study like this. So the question is, you have metastatic disease, in this case, colon cancer. Is there any benefit in resecting the primary tumor? And this assumes that the primary tumor is not causing symptoms. Okay, so can we improve survival or any kind of outcome just by resecting a primary tumor in metastatic disease? And in most cases, the result matches with this study, which is no. So there is really no benefit of upfront primary resection of a colonic tumor in metastatic disease. In a small minority of other cancers, this may be beneficial, but definitely not in colon cancer. Okay, so we're nearly done. Just a couple examples left. So this one I'm very excited about because some of my PhD work dealt with a cousin molecule of this drug. So this is an interleukin-15 superkine, they call it. It's basically IL-15, which is a cytokine that activates cytotoxic T cell, fused to some other proteins that help with stability. And this study showed that in patients with non-muscle invasive bladder cancer, okay, that's limited to the bladder and doesn't invade the muscularis propria, and in patients that have failed first-line treatment with BCG, if we actually administer this cytokine intravesicularly into the bladder, the complete response rate is really quite impressive. So 71% of patients have a complete response, and almost 90% of patients avoided a cystectomy, which is, of course, associated with a lot of morbidity if you have to go through this procedure. I know that this company and different versions of IL-15 are being tested in a lot of other clinical scenarios in cancer. So stay tuned for some additional approvals, hopefully in the near future. Another one here from genitourinary, from GU Oncology. So this is in clear cell renal cell carcinoma. And this is a really interesting cancer in that practically all cases are somehow related to hypoxia-inducible factor biology, so HIF. This protein plays a role, it's a transcription factor. It plays a role in other cancers, but here it's really a driver of almost all cases. And so finally, after really a lot of years of trials, including some here at we have an approval for belzutifan, which is a small molecule inhibitor of the HIF2A subunit of this complex. It's now approved for metastatic or unresectable clear cell renal cell carcinoma that has failed first-line therapy. And you can see in the bottom there the outcomes: significantly improved response rates and progression-free survival. So this is also FDA approved at this time. And just a couple more here on gynecologic cancers. We don't really treat these as medical oncologists, but this was another case of immunotherapy wins again. So I wanted to just briefly highlight it. Both in locally advanced cervical cancer as well as in metastatic cancer, we now have growing evidence that adding checkpoint inhibitors can improve outcomes. In the case of local disease, it's now FDA approved to add pembrolizumab to chemoradiotherapy for cervical cancer. And in the case of metastatic disease, the data are quite promising for adding atezolizumab to chemotherapy. This isn't FDA approved yet, but the study came out recently, so people are expecting that this will be approved soon. Do I have time? Maybe. So I think this is the last one, I promise. Okay. So this one's also another antibody drug conjugate for ovarian cancer. So a lot of ovarian cancers, it's another one of these diseases that is challenging simply because we tend to diagnose it at late stages. It's kind of hidden in the body, and we diagnose it late. So there's a need to have good and effective therapies that are safe. And this is a new one that came out. This is an antibody drug conjugate that targets folate receptor. which is overexpressed on a significant portion of ovarian cancers. And just like the previous example I showed to you, this brings a highly potent chemotherapy, sorvatansine, to the ovarian cancer cells using this antibody targeting folate receptor. The three mechanisms of action here, you will need these for your tests. So direct cell killing, bystander killing, and triggering anti-tumor immunity. Interestingly, there was a strange toxicity here with vision changes occurring in up to 10% of patients, and this was grade 3. So significant vision changes, not something we're used to seeing in oncology. I don't know if anybody in the audience knows the mechanism. I don't. I couldn't easily find it, but definitely something to watch for when using these agents. And I will stop there. Yeah, perfect.
Thank you very much, Dr. Watson. I think there's one question in the audience. Dr. Lakakis, can you unmute yourself?
Yeah, so the results with tarlatamab, the bispecific for extended stage small cell lung cancer in the refractory to platinum setting, to me, is more impressive than what we have nowadays. But the FDA approved it for third line. What do you think about that? Do you think it has to be on the second or third line?
I mean, I would prefer to use it in the second line, and I'll tell you why. Right now, people, the things we have are topotecan, sorry, which hardly anybody uses because it's toxic. It doesn't do much, and it's really just a couple of chemo agents that have very short progression-free survivals. Yeah, I think it should probably be tested for earlier lines.
Thank you.
Yeah.
Well, I'd like to thank both our speakers today for excellent grand rounds and presentations in their respective areas. It's a little bit of sadness that this concludes our grand round series for the year. We'll pick up again right after Labor Day. However, stay tuned because during the summer we will have some special presentations by visitors, and we look forward to everyone's participation at that time. In the meantime, please do check the chat for the link for the CME and MOC credits. And I want to particularly thank Dr. Amar Deshpande, our Vice Chair for Education, and Laura Pinzone for arranging grand rounds for this year. Thank you very much, and I look forward to everyone to have a healthy and happy summer and productive summer. And we'll be in touch, of course. Take care, everyone. Have a nice day.